the number and the size of platelets with our initial testing. And in this slide, this is what we're looking at in a microscope. The sort of red donut-shaped cells are the red blood cells. In the cartoon, those are the ones that are carrying oxygen in their backs. And then in the middle is the white blood cell. That was the police force. And then the platelets are these little dots, and they look about as big as, you know, if you were to put your pen down on a piece of paper. And in somebody with Glanzmann's, they look normal on our smear, and they're normal in number. So this test isn't very helpful in making the diagnosis of Glanzmann. When we look at the cells under an electron microscope, where we can make them really super big, these are the same three cells. So the divot in the middle of the red blood cell is very characteristic. The white blood cell is sort of fuzzy, and you can imagine it fighting infections. And that's a platelet that started the shape change. So the platelets normally circulate around minding their own business, and in order to do their job to plug up a hole on the side of a vessel, they need to literally turn themselves inside out, do this shape change. And then you can see once they do that, how they would be great at recruiting their friends and buddies to stick to the wall and stick to each other and create a platelet plug. What's happening inside on that blood vessel wall, and in the bleeding disorders read, you're probably familiar with this. So this is the blood vessel wall. We have von Willebrand's factor that recruits platelets using another receptor on the outside of the platelet, glycoprotein 1b, and that brings the platelet to the site of injury. But then the 2b3a, another glycoprotein receptor, is what we need to use fibrinogen to pull platelets so that we have that big platelet plug. And so if you're missing this receptor, you have what's called Bernard-Soulier. But for this audience, it's the 2b3a glycoprotein that's either not there or not working properly, and so you don't have that recruitment of more platelets to aggregate. And this is sort of step 3 of platelet aggregation. You've got shape change, then you have adhesion to the site of the injury, and then aggregation is where we're seeing an abnormality in Glanzmann's. And this is what I call the underside of the carpet. So this is what a platelet plug should look like. Those platelets reach out, sort of smear everything and cover up that injured area, and then other factor proteins seal that platelet plug. So this is the picture that's not on your handout. Sorry, I just thought it was really cool and colorful picture. When we look at testing, we know that there are a lot of things in the environment that contribute to making the platelets know that they are needed. And we can test for that in the lab using a bunch of agonists that mimic what's going on in the bloodstream when there's injury. So epinephrine, ADP are all agonists that do something to make platelets do their job. And so on the top is what those tracings should look like. And what's very classic about Glanzmann's and what makes it easy to do this testing when we're curious about this diagnosis is none of them work on platelets. So we have absolute flat lines. And then we have a test called ristocetin, which is not in our bodies. It's actually an antibiotic. But we know that it interacts with platelets, and we know that because it was used in the military, and when we were treating our servicemen with this antibiotic to treat infection, they were all becoming thrombocytopenic. So very characteristically, if somebody has Glanzmann's, when we do this test, all of the agonists are abnormal. Ristocetin is still completely normal. And the exact opposite is true when we do testing for Bernard-Soulier. So they have completely normal agonist reaction, but no ristocetin reaction. So we can distinguish with this test between the two. And then oftentimes we'll go on and do that glycoprotein testing and doing flow cytometry. How is this passed on? We know that this happens in about 1 in a million. It's very rare. And in the world of bleeding disorders, we're used to rare, but this is 1 in a million. And the reason for that is it's autosomal recessive. So in order to have a child or make somebody have Glanzmann's, both parents have the affected gene. And so with each pregnancy, there's a 1 in 4 chance of having a child that didn't inherit either of these mutations. There's a 50-50 chance of having a carrier, and then a 1 in 4 chance of having a child who has Glanzmann's Thrombasthenia. So obviously, that's why we don't see it very often. When we make the diagnosis, there isn't anything about Glanzmann's that makes you bleed. It's when something else makes you bleed longer. And so, as a nurse, an ounce of prevention can go a long way. talked a lot about identifying triggers. If somebody has nosebleeds, are there allergies that we could manage? Is it a particular seasonal trigger? We have some patients who bleed a lot in the summer because they're hot and dehydrated, or in the winter because of the dry months. So I'm a big fan of saline nasal spray and saline gels. Humidification is a little bit of a double-edged sword because while it can make the air more moist, if you're not cleaning the humidifier, it can also spread spores that contribute to environmental allergies. So it's definitely works, but with some care and maintenance. Hormone therapy can certainly help for somebody who's having menstrual bleeding. And then there are a lot of supportive care measures, and I know I can come up with a few, but I'm looking forward to the breakout to find out what is working for people, because I can take that back and share your expertise with my patients and families. Nasal cease is sort of like a Dixie stick that you can, I feel like it's, you lick it and stick it in the sugar, but it's sort of like a tamponade for your nose. Nosebleed QR powders. If you come to the hospital with a nosebleed, we often use topical thrombin, which can help manufacture a clot using thrombin from recombinant donors. Afrin is something that I like to reserve for our emergency room. It's a good vasoconstrictor, which is great because it can decrease blood flow, but what happens is if you're using it repeatedly, those blood vessels can sort of give up on constricting and they open up wider. So I like to reserve that for my ENT patients. And then oftentimes packing with gel foam or what we call a rocket. The caution with that, I always remind people, is that whatever they're using should be something that resorbs, because I don't want to have to go in days later and pull it out, because then it's going to take that precious clot with it. And then I'm going to turn it over to Dr. Chitler to talk about some of the therapeutic options and why we do what we do treatment-wise.
Good morning, everyone. Thank you very much for having me here today. And it's beautiful outside. At least the view from my window was very nice this morning. So I hope we'll give you some time to spend some time there as well. But I'd be very happy to answer as many questions as you guys have for me. I'm from Detroit, Michigan. And so let's get on with what we're trying to do today. So I guess Christine did a wonderful job explaining to us what exactly is happening in the Alzheimer's. So now the question is, what can we do about this? And is there something we can help with in terms of symptomatology? So one of the first things, probably the most simplest one, is to try to see if we can keep this clot in place. You do make a clot when you have Alzheimer's. It's just not a very good clot. And so if there's something we can do to hold it tighter and maybe keep it in place a little longer, and that might be something that will help take care of the bleeding symptoms in Alzheimer's. So how I look at antifibrinolytic agents are that something that prevents the clot from getting destroyed and keeps it in place and keeps it a little tighter for a little longer, so it helps there. So I think this is another slide where I'll go over it in detail. So there are two of these agents that we use quite commonly. One of them is Amicar and the other one is Lystera. Lystera is sort of the newer agent that we've had. We've had it in Europe forever, but we couldn't get it here in the US. And so, but it's now available, and I'm sure the girls are very happy about that. Because Amicar, as you guys all know, you take every 6 hours, whereas Lystera is only 3 times a day. So it's a huge improvement. And it's only 2 pills versus I don't know how many, 10, 12 that some of our patients have to take. So those are the two agents. So then, obviously we know that the problem is the platelet. So if the problem is the platelet, the way to really definitively fix it is to give you platelets at work. If your platelets don't work, if I transfuse you with platelets that do work, then I will be fixing the problem. Everything that we do, unfortunately, comes with a plus and a minus. Yes, I can definitely stop the bleeding if I give you platelets, but then there's a downside to it because I may cause other problems. So we have to think, when do I want to give platelets? When do I not want to give platelets? When can I get away with not having to do something as drastic as giving? Oh, sorry. Yeah. So if you can't hear me, please let me know. I can't scream. Because whenever you give platelets are a protein because it's part of your blood. Whenever you put something into the body that doesn't actually belong to my own body, my immune system is trained to react. other people's platelets into another person, that immune system is going to respond to this. And the response that it usually creates is to make what we call an antibody. An antibody is something that can attach to the non-self thing and attach and kill it. So if you develop antibodies, that means that these antibodies will fix to the platelets, whether they're transfused or not, and kill it. So then I've lost the ability to take care of what I was trying to do. And so we try to reserve a platelet transfusion for something that is life-threatening, where I really need this to work. And I absolutely have to make sure that I can stop the bleeding. So for example, if somebody was having an intracranial hemorrhage or a bleeding in the brain, so that would be a situation where I don't want to take any chances. I want to really make sure that this bleeding is stopped. Then I would put everything, all my eggs in one basket, and try to make sure that it works. So the one thing that I know will definitely help stop bleeding is to give platelets. So that's one thing to consider. And of course, we now have one more item in the agenda that we can use. It's called recombinant factor 7A. So it's actually a clotting protein. So it's one of the clotting proteins, like if you have a deficiency of 8 or 9, you have hemophilia, you can have a deficiency of factor 7. So this product was actually made to help patients who have factor 7 deficiency. But over time, we've learned that this can also be helpful in several platelet disorders. Okay? Because, maybe in this slide, I'll try to help you understand that part. Okay? So let's talk about the amicar and the lymphatic first. Okay? So this is our blood vessel wall, and typically it's very nice and smooth. It's perfect. And so that's the first thing that prevents any bad stuff from happening to us. The fact that our blood vessel lining is so perfect and so smooth. So all the cells, all the little guys that you saw marching along in that video, can march along without any interruptions. Okay? So when we have any kind of injury, for example, like that, so then there is an interruption to this really smooth flow of everything that goes along in the blood. So when there's an interruption to that really smooth flow and the platelets bump into this, or the 1 milligram factor bumps into this area, how I describe to patients what is 1 milligram factor, it's actually like a protein that's stacked. And you have to have a decent size stack for it to work well. So you can look at it like a slinky. Okay? So in its normal time, when nothing is happening, then the blood vessel lining is very smooth, the slinky is compressed, and it goes along like nothing is happening. When there's an interruption or a problem with the blood vessel wall or a bump in the road, this slinky gets stuck on the bump and then it gets stretched. So when the slinky gets stretched, there's an opportunity for all these platelets to come and stick to that slinky. And so then you get this little plug or little clump of platelets and 1 milligram factor that we call our primary platelet plug. So that's the first step in making a blood clot and trying to stop bleeding. Okay? And so that's what happens first. So you have the 1 milligram factor that comes and sticks here, and all these little yellow ones, I don't know if you can see it really well, get stuck to that area. So once that happens, then all the other cells are there too, and that's what makes a blood clot. So when the 1 milligram factor and the platelets come there, the platelets, like Christine said, have to change their shape. They have to develop all these arms so that they can hold on to each other. Okay? And so when this process of making arms and holding on to each other doesn't work, we have a problem with bleeding. Okay? When you don't make a good clot, the other thing that happens is that it doesn't bring along with it all the clotting proteins that are necessary to make a good clot. It's a combination of the platelets and the clotting factor that makes a good clot. If I don't have a good clot, then I can ooze forever. So when we don't have good recruitment of all these other clotting proteins, we don't make good clots, and so we tend to ooze a lot, which I'm sure all of you can relate very well to, especially the nosebleeds. So it seems like, yes, you have that initial gush, and then it seems like it stopped, but it just won't stop dripping. It just keeps oozing. And that's really why. Because we can't seem to stick together really well, and there's that constant ooze. Normally, in me and Christine, if we had a nosebleed, what would happen is, we would make a nice big plug, it would plug up that hole, and then in about 5 days, which is what normally the time it takes for any kind of wound to heal, and the lining underneath to be repaired, the body automatically gets rid of that blood clot. So that, because we don't want anything to be there longer than it needs to be. So once the body thinks that it's given enough time for this wound to heal, it gets rid of the blood clot. So we have proteins that actually help go there and dissolve that clot. But when you don't make a good clot, you don't have a good plug, it takes much longer for that lining to be repaired. But the body doesn't know that. The other proteins that dissolve clots don't know that. So at the end of 5 days, they just go ahead and get rid of the clot. But when that happens in a patient who has Glanzmann, you still have an area underneath that's raw. So you bleed again. So it's really important for that clot to stay in place much longer in a patient who has a bleeding disorder in order to allow enough time for that area to heal. And so when you take an antifibrinolytic agent, what it's doing is keeping that clot in place for longer than that 5 days. But in order for this to work, you have to actually take it for longer than 5 days. Okay, so it doesn't help to take Amicar for 1 dose or 2 doses. It makes no difference. You might as well not take it. All you got is probably an upset stomach. So you have to take it for beyond that 5-day period for it to work, because I want that clot to stay in place for longer than 5 days. Because that's what my body needs to heal that clot. Okay? So that's how the antifibrinolytic agents work. So it's really important for you to take that for the 1 week that your doctor said, or sometimes longer. If we think that you've had a tonsillectomy, and maybe that area is going to be raw for much longer than 5 days or 7 days, I'm going to have you take it for longer. And the reason is that I want that clot to stay there and not go away, so that I give the body time to heal.